All right, welcome colleagues to another tutorial on Saturday. And we started last week on hemodynamic monitoring. And we'll proceed from where we stopped. First and foremost, let me also let you know that each of these monitoring devices or parameter can actually suffice for a tutorial topic. So we can talk about arterial blood pressure monitoring as a topic itself. But we're trying to condense all of this together so that we can have an overview of this hemodynamic monitoring. I got this quote from one of the books I used by Albert Easton, and I think it's relevant concerning hemodynamic monitoring. It says, not everything that counts can be counted, and not everything that can be counted counts. And this is very true, especially in the intensive care unit. So we looked at arterial blood pressure monitoring last time. We looked at general monitoring. We looked at the non-invasive or the indirect blood pressure monitoring. And we looked at direct blood pressure monitoring. And we looked at, I think where we had some interesting discussion was on damping. Okay, yes, the arterial waveform and damping. So we did say that the most important thing about the system is to have a well-damped system. What it means is that the ability of the system to return to its resting oscillation after distortion, after being distorted. And we talked about underdamped and overdamped waveforms. We mentioned this. Underdamped waveform, the waveform is narrow and peaked, so it will overread the systolic blood pressure and underread the diastolic blood pressure. So it's important that we understand this. When the system is overdamped, all right, the waveform is blunted, and this will underread the systolic blood pressure and overestimate the diastolic blood pressure. So one of the things that we must regularly do is to check. We can do damping check by what we know as the square wave test, what we know as the flush test. All right, every of the system, the kit, arterial line kit has a device, a flushing device. All right, it can either be something you pull or something you close. So to do a square wave test, you flush the A line by pulling the flush device for 1 to 2 seconds. And when you do that, you observe the waveform rising sharply and returning to the baseline when the flush device is released. So you know your system is optimally damped. That's what you want to achieve when you see 1 or 2 oscillations before the waveform returns to the baseline. If the system is underdamped, you'll see 2 or more oscillations. All right, when it's overdamped rather, you'll see little or no oscillation before the waveform returns to normal. So this is how to ensure your system is optimally damped. And a lot of times when you do this, you see that your waveform returns to normal. All right, so we talked about this. So today we're going to talk about the central venous pressure. All right, so I'm still getting a lot of responses. Every Saturday is okay. Fortnightly is good. We'll think about that. So central venous pressure, this is important. And as a means of monitoring, both in the ICU and the OR. So likely exam questions, you see questions like this. What are the indications for central venous pressure measurement in the operating room? All right, the second question is mention at least 5 contraindications to central venous catheterization. And the last one is draw and label in normal CVP waveforms. Maybe I will add a fourth one to read, what are the different pathological waveforms that can be recognized on your CVP, because it's not just enough to know the normal. It's important for us to be able to recognize deviations from normal. So these are the likely exam questions we hope to provide answers for as we go on in this discussion. So what is central venous pressure? Actually, this refers to the venous pressure of the right atrium, okay, and of the great vessels of the thorax. All right, it also refers to the diastolic filling pressure of the right ventricle. So there are two things there: the right atrial pressure, which correlates with the central venous pressure, both of the IVC IVC, all right, or the central venous, the superior vena cava, all right, and also the diastolic filling pressure of the right ventricle. The normal value ranges between 2 to 6 if you are using millimeters of mercury, or 2 to 8 if you are using centimeters of mercury. It's important that your CV measurement should be taken at the end of expiration to avoid the impact of respiration on the CV measurement. All right, the catheter, I'm sure many of us are familiar with this. Usually made up of polyvinyl product or biocompatible polyurethane or silicone. This makes it durable and lasts longer. All right, and it comes in various lengths, typically between 50 to 30 centimeters. It also depends on the site. All right, and they often have multiple lumens. Most of the ones we're used to are triple lumens, and each will have separate channel fluids. All right, and usually contains a radiopaque line, all right, which makes it visible on X-ray. One of the things we talked about central catheterization, venous catheterization, is you need to confirm placement. So, and one of the ways to confirm correct placement is to always obtain a chest X-ray after insertion of a CVC. It is a must. It's standard of practice that after you have inserted a central venous catheter, you must obtain a chest X-ray to confirm correct placement. All right, and what makes you to be able to do that is a radiopaque line that is embedded in the tubing. All right, so there are different indications. Just to help our trainees, just remember your mnemonics is CVP, all right, and you provide, the full words for it. So administration of fluid, okay, multiple fluid transfusion, all right. Note that it is not ideal for rapid transfusion because of the caliber of the lumen, but for multiple transfusion, CVP is indicated. All right, CVP can also be used in case of embolism to aspirate air. All right. More importantly, it is used to measure the central venous pressure, which also equates to your right atrial pressure. Venous blood sampling. All right, this is one of the indications for it. A lot of times we do regular, frequent venous blood sampling in ICU. So it's instead of just doing phlebotomy all the time, you have your central venous catheter where you can do your blood sampling frequently and regularly as may be indicated. All right, administration of vasoactive agents. All right, these drugs are usually administered through a central line. All right, pacemaker insertion. All right, through your central venous catheter, parenteral nutrition. All right, and when peripheral lines are inaccessible in patient bones to the extremities. All right, patients who are obese that you can't access the peripheral line. So if you are asked what are the indications of central venous catheterization, just write A, CVP, and you fill in the other ones. You won't miss it. So 1, 2, 3, 4, 5, 6, 7, 8. you can actually be able to write 8 to 10 indications of central venous catheterization. What are the contraindications? All right, in CVP, infection at the site of insertion, patients with previous neck surgery, or patients with neck masses, all right, especially patients with thyromegaly may be difficult. Coagulopathies, all right, there are patients that are coagulopathic with INR above 2, and a lot of times you want to also pass the central line. And this one, depends on also the site. If I have a coagulopathic patient that requires a central line, I would rather use a central vein that is compressible. I would not want to use a subclavian route. When you have contralateral diaphragmatic dysfunction, right, you want to avoid putting a central line in that area. When you have venous cavernous syndrome, or patients who already have pacemaker inserted in that site, all right, these are some of the contraindications. There are complications, a CVP arterial puncture, and many of us who have done central line will know that if you have not punctured an artery, your common carotid artery or femoral artery, maybe you haven't done enough. So arterial puncture, embolism, and that's why you must have reverse of the labor position. All right, chest infections, you can introduce infection, venous thromboembolism, you can have pneumo or hydrothorax or hemothorax, and these are usually the complications are usually reduced or minimized with the use of ultrasound-guided CVP insertion, central venous catheter insertion. All right, so a lot of times when you're passing this, you want to see your tracing on your monitor, and this is what a normal CVP tracing looks like. Okay, we have 3 peaks, the ACV, and we have 2 troughs, the X and Y, and we're going to look at it. If you see it correlate with the ECG, each of them has importance. So in normal CVP waveforms, in answering the questions that I asked before, all right, in normal CVP waveforms has 3 peaks, the ACV and the 3 descent or troughs, the X and Y, and each of these waveforms, all right, result from the ebb and flow of blood in the right atrium. The A wave corresponds to increased arterial pressure from the right atrium. All right, a lot of times it corresponds to the P wave on your ECG. The C waves is due to a slight elevation of the tricuspid valve into the right atrium during early ventricular contraction. All right, this corresponds to your QRS complex on your ECG. The V wave arises from pressure due to blood filling the right atrium with a closed tricuspid valve. All right, this is corresponds to the end of your T wave. The S descent is caused by downward movement of the ventricle during systole, and the Y descent is caused by opening of the tricuspid valve in diastole. All right, this usually occurs before the P wave. The opening of the tricuspid valve in diastole, all right, leads to influx or flow of blood from the right atrium to the right ventricle. All right, so this is just to tell you, all right, this is just a reminder. The A wave, all right, corresponds to atrial contraction. The C wave is when your tricuspid valve, the valve between your right atrium and right ventricle bulges out. And V wave is the systolic filling of the atrium, all right? So this is how you do the tracing. So if you're asked, this is how the central venous tracing looks like. I think you should practice it and become second nature to you. All right, most of the times central venous pressure correlates with, like I mentioned, is usually used to assess the right atrial pressure, which corresponds to your central venous pressure. Is also used to assess fluid status and response to fluid bolusing. So if the increase in your central venous pressure you measured before and after 5 minutes of fluid bolusing is just 0 to 3 milliliters of mercury is an indication that your patient requires more fluid. If the increase is between 3 to 5 from the baseline, it shows that your patient has adequate fluid loading. All right, please mute your mic upon entering. If the increase is more than 5 millimeters of mercury after fluid bolus, is an indication that you should stop fluid loading. So these are very, very important, especially in assessing fluid status and response to fluid bolus in our patients. Okay, so we have pathological CVP waveforms. In atrial fibrillation, the A waves will be absent, all right? And you'll see Canon waves, which are increased exaggerated A waves during the atrioventricular dissociation, all right? When you have triascopic regurgitation, all right, you'll see positive wave of regurgitation replacing your C and C wave and your S descent. When there's cardiac tamponade, all right, all the pressures, all right, are elevated. The right pressure, the right heart pressures are elevated, and you will see absent wide descent. So just looking at the CVP waveforms, you can have a lot of information that will help you in management of your patient. All right, so that is central line. Like I mentioned, each of these parameters of monitoring parameters can actually be a full, presentation. We was talking about central venous pressure. We could have talked about insertion. We could have talked about, the different routes, but just because it's part of hemodynamic monitoring, we restrict ourselves to this. But if you have any questions, we can discuss at the end of the presentation. All right, the pulmonary capillary wedge pressure, the introduction of the pulmonary artery catheter actually, is one of the defining moments in critical care alongside introduction of positive pressure ventilation. So these two really has done a lot in management of patients in the critical care unit. So PAC, pulmonary artery catheter, is one very important parameter. All right, so the questions regarding pulmonary artery catheter, answer the following questions. These are likely exam questions. Number one, describe the principle of pulmonary artery flotation catheter. All right. Because of time, I would have wanted somebody to quickly do that, but let's go on because of time. Enumerate the hemodynamic parameters that can be derived from your PAC, your pulmonary artery catheter, and discuss the drawbacks of pulmonary artery catheter. These are likely exam questions that you should have on your fingertip. All right, so let's look at the pulmonary artery catheter, also known as Swan-Ganz, named after the two Italians who discovered this. All right, it's also known as the flow-directed balloon-tipped pulmonary artery catheter. Right, and was first described in 1970. It's available in different sizes, ranges between 60 to 110 centimeters in length. All right, the balloon inflation volume ranges between 0.5 to 1.5 ml of air or saline. And the catheter is made up of PPC, which is pliable at room temperature, or and softens at body temperature. Each of the catheter is marked at 1 cm or 10 mm increment, and this helps you, all right, during insertion. All right, catheters may vary, but a lot of times we have a 5 lumen catheter with different additions depending on manufacturer's specifications. All right, maybe I should just quickly mention here. All right, maybe I should quickly mention here the insertion. All right, you use your Sedenga technique. All right, and during this, it's important for us to know it is done. You attach a pressure transducer, all right, to the distal end of your PAC catheter, And as you pass it, all right, as it passes through the right side of the heart, the right atrium, you see the venous waveforms. All right, it helps you to know where you are because the different chambers of the heart will begin to give you different waveforms. So as it passes into the pulmonary artery, the blood, the balloon is directed by the flow of blood through the pulmonary artery system, all right, and takes it to its location, all right, in the pulmonary artery. Once you are in the pulmonary artery and you're able to get that waveform, the arterial waveform, you can inflate your balloon with 0.5 to 1.5. And this what happens is that it helps to wedge the balloon in the pulmonary artery system. And that pressure you take at that point is called the pulmonary artery occlusion pressure or the pulmonary capillary wedge pressure. And this is important because it determines the flow status of the patient. It also helps you to rule out pulmonary artery hypertension. So it's important for us to remember how the catheter is inserted. All right, there are about 5 components. When I was training, I had to develop this, because it was a very popular question during those days. So patients brought in dead. The first lumen is the proximal lumen. All right, this terminates about 30 centimeters from the tip of the catheter, and the proximal lumen is used for injection, not infection, and injection of your code injected. And we're going to see that as we move on in cardiac output measurement. We have a thermistor lumen that terminates 4 cm proximal to the tip of the catheter, all right, which is helpful in measuring temperature, all right, of your injected and is useful for cardiac output measurement. The balloon lumen, all right, this is for inflation of balloon, like I mentioned, and it helps to monitor or measure your pulmonary artery occlusion pressure or your pulmonary wedge pressure. All right, we have infusion lumen for infusion of fluids. The distal lumen, this is important. The distal lumen measures the capillary wedge pressure and also for sampling central venous oxygen. All right, the SVO2. And we're going to be looking at that as time permits us, because you can actually get about 8 to 10, parameters from your properly inserted or properly placed pulmonary artery catheter. All right, so this is an example of your pulmonary artery catheter. Some authors call it the yellow snake, all right? And these are the different parts. This is the thermistor part, the proximal part for your injected, the pulmonary artery, all right, for your pulmonary capillary wedge pressure measurement. This is your balloon, all right? So this is an example, all right, of a pulmonary artery catheter. This is almost about 110 centimeter and is marked at 110 centimeter, 1 centimeter, that is 10 millimeter graduation. So it helps you. All right. At the beginning, you have to put your your pressure transducer at insertion, so that as you pass through the different parts of the heart, you can see the different pressures being displayed. It helps to tell you which parts of the heart you are in. Now, there have been indications for PAC. I put it at PaO2. So it is useful for passing a pacing wire, all right, just like your CVP, all right. And it's useful also for ruling out of diagnosis of ARDS. So when your pulmonary capillary wedge pressure is less than 18, don't forget that ARDS is pulmonary edema of non-cardiac origin. Okay, it can tell you about oliguria, pressure state in shock, cardiogenic, and septic shock. And very importantly, is that it is also useful for measuring CVP. All right, so instead of passing CVP separately, the pressure at the right atrium is equivalent to your CVP. All right, and it's also useful for your right end diastolic pressure. So these are some of the indications for passing your pulmonary artery catheter. All right, so the measurements you can get from them, the pulmonary artery occlusion pressure gives you an accurate and indirect measurement of your left atrial pressure or your left ventricular end diastolic pressure. All right. The pulmonary artery systolic and diastolic pressure gives an estimate of pulmonary hypertension. So when you have your PaO2, all right, greater than the pulmonary capillary pressure greater than 15, for instance, all right, or the pulmonary artery pressure greater than 15 gives you an indication of pulmonary hypertension. Thermal dilution, you can use that with the measurement of the temperature change of your injectate. All right, can be used to measure your cardiac output. You will see that in the subsequent slide. Now, this is important, missed venous oxygenation saturation. All right, a high SpO2 greater than 80 shows increased oxygen supply or reduced oxygen demand. A low SpO2, all right, with less than 65% shows you a low cardiac output state because it gives more room for oxygen extraction. All right, when it is less than 40%, it implies a critical oxygen supply demand imbalance. And this is important. All right, it actually correlates with your SCVO2. And this can actually be gotten by, getting your venous blood from your catheter, your central venous catheter, and measuring it with your ABG. And don't forget that in your early goal-directed therapy, SpO2 of 70, all right, is desirable to show adequate perfusion and adequate cardiac output. So SpO2 less than 65% is indicative of low oxygen delivery, all right? And the implication is that low cardiac output state, the blood is sluggish and we have greater extraction of oxygen. All right, I mentioned this before, it helps you. The pulmonary capillary wave pressure, pulmonary artery pressure, occlusion pressure indicates the likelihood of edema forming in the face of normal pulmonary permeability. Right, it represents your left ventricular end diastolic pressure, which is an indirect indicator of ventricular end diastolic volume. And if you remember the Fick principle, the Franklin law, all right, your cardiac contractility is highly proportional to your myocardial fiber length, and this is all can be gotten on measurements of your pulmonary capillary wave pressure. All right, so this is your normal PCP waveforms. It resembles a venous waveform, and it swings with respiration. So most of the time, these venous waveforms are actually taken at the end of expiration to reduce the influence of respiration on their values. All right, I hope you're following. I hope I'm not too fast. I just want us to finish hemodynamic monitoring today. So the next important one is cardiac output measurement. All right, likely exam question. Mention the different methods of cardiac output measurement. Describe any two of these methods. All right. So now the first one we're going to look at, I have a mnemonics for a cardiac output measurement, FEDECO. All right. Federal Election Committee. All right, FEDECO. Don't forget that. So the first cardiac output measurement makes use of the Fick's principle, which was described in 1870 by Adolf Fick, all right, and the formula is here. So cardiac output is equal to, oxygen consumption, all right, total oxygen consumption divided by the oxygen concentration at the artery and the oxygen consumption content of the vein at the venous end. So this will give you the cardiac output is about 4 to 6 liters per minute. So the Fick principle states that blood flow to an organ Let me mute. All right, so the fifth principle states that blood flow through an organ in unit time is equal to the amount of a marker substance. The marker substance we are using here is oxygen that is taken up by the organ per unit time, divided by the difference in concentration of the substance between the arterial and venous blood. All right, so the blood flow is used to calculate, the total cardiac output. So that is how this is done. The second method of cardiac output measurement is the echocardiography, which can be a two-dimensional or three-dimensional echocardiography, or you can actually use the transesophageal echocardiography. All right, what this does, those of us who are used to, all right, now this is a parasternal long axis view. You can see the left ventricle on the left side, but if you are using the apical 4 or the parasternal short axis, in fact, the parasternal short axis is better because you see the papillary muscles, and you can see, the movement of the ventricular walls, and it is used to visually, assess cardiac output. So from here, a two-dimensional echocardiography measures the movement of the anterior and posterior ventricular walls. Most of the time we do focused cardiac ultrasound because we're not cardiologists that will measure the details. We just look at the way the posterior and the anterior ventricular walls try to touch each other. We can use it to gauge the injection fraction. And this stroke volume, the amount of volume of blood that is ejected from the ventricles per cardiac cycle can be used to can be calculated from the ventricular activity. The transesophageal echocardiography, you have a probe, all right, that is passed, all right, into the esophagus, all right, close to the heart. And this depends on the Doppler principles, which measures blood flow velocities across heart valves, especially the aortic valve. So by combining this velocity that is recorded from the system, all right, you can measure the left ventricular outflow diameter. And all of this can be computed in your microprocessor to give you a stroke volume. And when you multiply this with your heart rate, you have your cardiac output. All right, the dilution techniques, all right, in the dye dilution techniques, we have a known amount of a dye. Most of the times we use the indocyanic green dye because of its low toxicity. It has a short half-life and very good absorption characteristics. What it means is that it is not affected by changes in oxygen saturation. So you do this and it's plot pressure versus time curve. All right, the pressure versus time curve, and cardiac output is calculated from the injected dose, the area under your pressure time curve. All right, and its duration can be used. Curves of short duration are produced by high cardiac output, and those with long curves are produced by long cardiac output. So you can use that. Another dye you can use is the lithium, all right, which is injected and is measured. The concentration is measured by lithium-sensitive electrode, which is incorporated into the arterial cannula. All right, another dilution technique. The first one we mentioned is the dye dilution technique. Another dilution technique is what known as the thermal dilution technique. Let me say here that the sensitivity of this technique depends on the temperature of the injected and the volume. So injected with lower temperature and high volume, all right, measures more accurately the cardiac output. So what we do here, we give about 5 to 10 mils of your cold dextrose or saline through the proximal port of the pulmonary artery catheter, and the temperature changes is measured at the distal port with a thermostat. All right, the injection is at the end of expiration. So you plot a temperature drop against time. All right, the temperature drop from the proximal port, all right, to the distal port. The temperature is measured with a thermistor at the distal port of your pulmonary artery catheter. And this, you get the cardiac output by using the Stewart-Hamilton equation. Note that an average of at least three readings is used, and these 3 readings shouldn't be different from one another by 10%. If it's more than 10%, the measurement is not accurate. So you take 3 readings, all right, and an average of it is used to compute, all right, the cardiac output through this method. The Stewart-Hamilton equations on this slide, you can have time to look at it. All right, the PICO system. The thermodilution and the dilution, they are cumbersome, all right? You need to keep injecting, you need to keep measuring, and you keep plotting. But the PICO system provides a continuous and accurate measurement of cardiac output, all right, and all the parameters such as your preload and afterload. That the PICO system combines both the thermodilution we mentioned before and the post-contour analysis. And this gives you a more detailed real-time assessment of a patient's cardiac output and a circulatory system. Don't forget, like I said, it combines both the thermodilution and the post-contour analysis. The post-contour analysis helps to measure the area under the systolic portion of the arterial waveform, all right, to estimate both the stroke volume, and you use that to calculate your cardiac output by multiplying it with heart rate. The LITCO system, or just like the PICO system, this one, instead of using the thermodilution, it uses the lithium dilution for calibration, and you use your pulse power analysis, all right? A small dose of your lithium is injected into a central vein or your PAC, and concentration is detected by your sensor, all right? The system measures the lithium dilution curve, just like the concept of thermodilution, and it's computed through the Stewart-Hamilton equation. So the first thing is that you need to calibrate the system with your lithium dilution method, and it gives you a continuous measurement of your cardiac output. The last one we're talking about is the NICO system. All right, instead of using oxygen consumption, the NICO system uses carbon dioxide, that is exhaled. All right, so the NICO system, assesses cardiac output based on changes in exhaled carbon dioxide levels. So what happens is that there's a special rebreathing circuit that's attached to the patient's ventilator. And this rebreathing allows periodic, rebreathing of exhaled carbon dioxide, which is measured, all right? The concentration of the carbon dioxide that is rebreathed is measured in the alveoli, and the changes in carbon dioxide concentration during rebreathing is what is used to estimate pulmonary blood flow. From here, cardiac output is then calculated using the relationship between pulmonary blood flow and carbon dioxide exchange. All right. Now, all of this, cardiac catheterization needs to do with, whether you're doing your CVP or your PAC. And there are some questions, I found some questions that will say, what are the indications for cardiac catheterization? All right. So apart from hemodynamic measurement or evaluating the left ventricular function, cardiac catheterization can also be used during coronary artery disease, all right? And it also can be used for treatment and evaluation of cardiac arrhythmias. So this slide is just to give you an indication of cardiac catheterization in the ICU. The esophageal Doppler, all right? The esophageal Doppler, a Doppler probe is inserted into the patient's esophagus and is close to the thoracic aorta, where blood flow is measured. It's also based on Doppler principle, all right, which talks about the shift in frequency as the ultrasound wave is reflected back from the moving red blood cells in the blood. All right, this is combined with cross-sectional area of the descending aorta using a nomogram And a lot of times it's also, similar to the measurements of your trans-esophageal echocardiography. The difference here is that esophageal Doppler uses ultrasound, while your toe uses your echocardiography for the measurement. All right, so there are a lot of information you can get from your esophageal Doppler, and you can use that for it. So I just provided this slide to look at the differences between your toe and your ODM, esophageal Doppler monitoring. You can go through that when you get the slides. So these are my references. I make sure we finish today. So the floor is open. I'm going to stop recording. The floor is open for questions at